because everyone's raving about HRT, but what can we do? And I know that you've got lots of advice on what you can do if you've been through, because it's not just breast cancer, actually, is it? There are other cancers that can affect and push you into an early menopause. So
Absolutely, yeah. There's lots of different treatments, drugs, not even just for cancer actually, but other drugs sometimes can block the way the ovaries work and block
that's right.
hormones. So yeah, there's lots of people that are almost forced into a menopause unnaturally, and as you know, that can often be harsher. And sometimes people have their ovaries removed, and obviously as soon as their ovaries are removed, then they are menopausal forever. And some treatments, as you know, are temporarily cause a menopause, and others are more permanently.
Yeah,
so it really varies.
when you say that if you have your ovaries removed, because that's an option that's on the table for me, actually, to have my ovaries removed, and the thought of it absolutely petrifies me, because I've been pushed into the menopause once already, and then I think my body just makes too much estrogen, because I've now come back out of the menopause, and I'm sort of having a bit of a party again and enjoy, things are good.
Yeah.
And I feel like I've got a bit of PTSD in that I'm like, I just don't want to go back. I don't want to go back there. But anyway, shall I go through some of the comments that I've had sent to me, and then we can perhaps chat about that. Is that all right?
Yeah, absolutely. I'm fine to talk about anything.
Lovely. So one of the things was, and it's the main overriding thing that people contact me about, is when you've had a hormone positive cancer, a hormone positive breast cancer, what can you take to help you get through the menopause? Because it's like the gift that keeps on giving. You think that you've treated the cancer and then you're on your merry way, but actually for a lot of us, the menopause side effects is horrific.
Absolutely. So I think just before I get started, I'm hoping that two of my colleagues, Dr. Sarah Ball and Zoe Hudson, who's Manchester Menopause Hive, will be answering some of the questions below. Just so if you
brilliant, thank you.
So keep answering.
Great. So keep your questions come. Great. Okay.
I won't be able to answer all of them. And the other thing also before I get started is that all I can do tonight is give very general advice. So I don't want people there listening thinking that they can do one thing or another. But I think the first thing really probably is to sort of set the scene almost. And as a lot of people listening know, that 1 in 7 women will develop breast cancer. So it's very common. When I was a medical student, it was 1 in 12. So it's become more common. But most women, thankfully, don't die from breast cancer who've had breast cancer. So that's, the prognosis is so much better, which is great. But many of the treatments, as you know, cause menopause. But also, because women are living longer, they will go into a natural menopause as well. So there's very few, thankfully, women who've had breast cancer that don't experience a menopause, if you see what I mean.
I see what you mean. Yeah.
2 menopauses, like you say, have the treatment, come out and think, great, I'm getting my periods back, and then they'll go through a natural menopause. Yeah. Their ovaries just decline. And so certainly when I look at the evidence, it's really hard to know exactly what is safe and what isn't safe. And if we talk at the beginning a bit about the whole hormone HRT thing, and then we can talk about other treatments and alternatives and everything else.
Yeah, great.
Include everyone. But when we look at HRT, it's so scary for so many people, these 3 letters, and even for women that haven't had cancer or breast cancer, they're still really scared of it. We know the minority of women take it because for the last 20 years everyone's been scared actually about HRT. Us as healthcare professionals have been really scared, women have been scared, journalists have been scared. So when you're scared of something, it's just easier to say no, isn't it? It's so much easier.
So true.
And actually for doctors, it's like the easy option is to say no, because then no one's going to sue them, no one's going to get them into trouble. But actually we have to think about why we're refusing something. So if you think about our hormones, obviously estrogen is a really important hormone, and not only does it help our body's function, but it reduces risk of further diseases as well, because we have estrogen that stimulates every cell in our body. So it is a really, really good hormone. But then what happens if you've had an estrogen receptor positive cancer? And this is where it's actually really confusing, and I wish I could give everyone the answer tonight, but I can't, because this research hasn't been done, not because I don't know the answer. But how bad is estrogen in women who've had an estrogen receptor positive cancer? And that is something we can't answer. If you talk to oncologists, so cancer specialists, they will say, oh, most women shouldn't have any estrogen in their body, it will block, and then the prognosis is so much better. But if you look, when a woman's had breast cancer, the thing that actually is most important is the removal of the cancer, so the surgery. Radiotherapy also, for a lot of women, depending, obviously there's so many different types, grades, stages of cancer, so this is very general what I'm saying, but the radiotherapy is also very beneficial. And then chemotherapy, for those that need chemotherapy, again, is really important. Yeah. And then you look at the hormone treatment, so treatments that block the hormones functioning, then usually for people, the benefit is actually quite small. Now, when you're looking at treating tens, hundreds of thousands of women, a small benefit is actually really good, because it will help quite a few women. But you've also got to realise that there's a lot of women who are over-treated. I mean, and how do you know as an individual whether you're going to be one of the ones it will make a difference to, or one of the ones it won't make a difference to? And that's something that's very difficult to answer. So for some people, it's like, it's a very simple thing, thinking that estrogen is bad, let's block estrogen. But if you look at something like tamoxifen, it's not a complete estrogen blocker. It can act as an estrogen in some tissues and an anti-estrogen in other tissues. So that's why, for example, women have to have their lining of their womb monitored, because it can stimulate the lining of the womb in the way that estrogen can. And so then...
How do you know if that's happening?
Well, usually people have bleeding. If there's problems lining the womb, they get bleeding, and it's something that usually women who are on tamoxifen are warned that if they have bleeding, go and have a scan and make sure that there's no thickening of the lining of the womb. So it's not as simple as just blocking estrogen in the body. And so actually, before tamoxifen came on board, estrogen used to be a treatment for breast cancer, which is really weird for people to think about when you think, well, we're told we can't have estrogen. What's that about? Yeah. But estrogen is very powerful, and it can stimulate the immune system. And when the immune system's stimulated, it gets rid of nasty cells. And obviously bugs, infections are nasty cells, but so are cancer cells. Yeah. And so they can actually cause something called apoptosis, which is programmed cell death. So they can actually force bad cells to die. And so that's how it was used actually for treatment of breast cancer in the past, before tamoxifen came on board. So then we think, well, how bad is it? So we know that there's estrogen receptors in the cancer, but we've also got estrogen receptors all over our body. So if I took out a lump of my arm, my muscle in my arm, not that I would, but if I did and looked down at the microscope, it would have estrogen receptors in it. Right. So, you know, and so then just because it's got estrogen receptors in it, I've already said there are estrogen receptors on every cell in our body. Does that mean that's a bad thing? And that's where it's very difficult with breast cancer. We don't know. There have been a couple of studies where they've given women who've had breast cancer HRT, but they were quite small studies, and one of them, called the HABIT study, which is a hormone replacement after breast cancer study, was giving older types of HRT. And as many of you know, there are risks with older types of HRT, only small risks, but the natural body identical hormones that we prescribe are actually safer even with respect to breast cancer. So there was another study called the Stockholm study, which used less of this synthetic progestogen. And that actually showed that there was no increased risk of breast cancer in women who had HRT. There were 2 deaths in the study. There were 378 women in the study. Yeah. There were 2 deaths on women on treatment, but there were 4 deaths on women not on treatment with HRT. Right. So then they followed them up. They followed them up for over 10 years, and there's been no increased death for women taking HRT. So
that's so interesting.
It's really interesting. But that the study was stopped early because everyone got scared of HRT, because 20 years ago everyone being scared. So that was quite a small study, only, like I say, just over 350 women. So it's not big enough to say yes, that's relevant, or no, that's not relevant. But it doesn't show that it's really harmful. And so that makes it really difficult then to know, well, how harmful is it to have estrogen back? And the other thing is looking at what other benefits are there in the body for estrogen. So women who've had breast cancer are still at risk of osteoporosis, diabetes, heart disease, dementia. You know, women can get any disease even when they've had breast cancer. So most women who've had breast cancer actually die from dementia or heart disease like the rest of us, not from breast cancer.
Yeah.
So and then so then if someone comes to me, for example, in my clinic, who's floored with menopausal symptoms, they're literally just existing rather than living.
Yeah.
And they want to consider HRT, then it's looking at what are the benefits. Well, we know there are benefits for improving symptoms, but also for future health. Taking HRT reduces risk of heart disease, dementia, things that will kill us. Is it going to increase their risk of breast cancer? And this is where women need a very individual consultation. I can't say yes and no, but even if the woman's sitting in front of me, often what we do is look at factors. So we look at how long ago was the breast cancer diagnosed? What size of the cancer was it? What type of cancer was it? And then we often put in the predict, there's a predict NHS tool that I'm sure you've seen, where you put in everything.
Yeah.
And then you look and see, well, how much benefit is your hormonal treatment?
Yeah.
And then sometimes if someone's really struggling, but they're on an aromatase inhibitor, then we might say, well, just come off the aromatase inhibitor, have a drug holiday for 6 weeks.
Yeah.
Nothing awful's going to happen then, and you can get a feel for how you are. Some women then might decide to, if they feel better on that, go on to tamoxifen, which works slightly differently. Obviously, the aromatase inhibitor zaps every single cell of estrogen out of the body, whereas the tamoxifen is a bit kinder, if you like.
Right.
And then some women still have symptoms, so then they say, well, I might try HRT and put on a low dose and keep the tamoxifen going, because that might protect some of the tissue, the breast tissue or something. So it really, really varies. There's never a no. You cannot definitely have HRT if you've had breast cancer.
Can I ask, can you take HRT if you are on tamoxifen? Can you take the two together?
That's a really good question. And yes, you can. There isn't, again, the lack of evidence drives me mad in the whole menopause area, because no one has funded good research. And as you know, I've just founded the Menopause Charity. So the more donations we have, the more this sort of research needs to be done. But there is this thought that, maybe if you're on tamoxifen, it will protect the way that estrogen works on any cancer tissue. So some people do. They prefer the thought of taking them both. Usually if someone's on it already, then I would say, well, keep on it. But I wouldn't necessarily start someone on tamoxifen who I want HRT, who's going to start HRT. Now, there are some women, if I've seen women in my clinic who have had breast cancer 20 years ago, and then they've gone through then a natural menopause, really struggling, and everyone's saying, no, you can't have HRT. Well, after 10 years, most oncologists think, well, the woman's risk of breast cancer is the same as someone who hasn't had breast cancer. 10 years. I know breast cancer can appear, and it's a very unusual cancer compared to some of the others, but generally speaking, if it's been a long time, you can be more reassured. The other thing is that we see a lot of women who've had breast cancer when they were quite young, had their treatment, and then, like you, periods have come back, and then their oncologists have actually said, oh, well, that's good, your periods have come back. And then they've gone through the natural menopause, and everyone's saying, oh, no, you can't have HRT. And I'm thinking, well, what's the difference, actually?
Yeah.
All I'm doing is topping up their hormones with the same hormones they've been producing sometimes for years.
Yeah.
And when I challenge oncologists, they're like, oh, yeah, I hadn't really thought about that.
Would you agree with the fact that going into a natural menopause is kinder than when you're forced into one after?
Usually it is. It's usually that it's very harsh on natural menopause if it's a surgical menopause or it's done by drugs. The other thing is, obviously, a lot of women who have chemotherapy have chemotherapy side effects.
Yes.
And they're menopausal. And so I've spoken to a lot of women who've had chemotherapy and all the brain fog, the bone pain, starting the low mood. Everyone said, oh, it's your chemo, it's a chemo brain. Well, it's probably not, or it might be mixture, obviously. And so the problem is also, though, Helen, is that oncologists aren't really trained on the menopause. And also, for women who've had breast cancer, obviously it's a huge diagnosis. You've got massive hurdles to get through. And if someone says, oh, your drugs might cause the menopause, well, that's not the least of your problems, or worry, really. But actually, once a woman's gone through the majority of her treatment, the menopause is there forever. And it's really important that women aren't neglected. It's almost like they fall off a cliff and then they're like, who's going to pick up the pieces? How am I going to carry on with my life? And I feel desperately sorry for so many women. And so we've got all this systemic, we talk about HRT, but actually a lot of women, the majority of women, experience localized symptoms. So symptoms such as vaginal dryness, soreness, comfort, recurrent urinary tract infections, a bit of leaking, coughing or sneezing. These are all symptoms because there's low estrogen in the vagina, the pelvic floor, but also the bladder and the urethra as well.
And would that be joint pain as well?
Well, the joint pain is a systemic, which will help with systemic HRT, but the localized symptoms will respond to local, so vaginal estrogen, which is not HRT. So it's really important to mention here, because the vast majority, probably all women who've had breast cancer, can safely use vaginal estrogen.
As a pessary? Is it like a pessary?
There's a pessary, there's a gel, there's a cream, there's a little ring, actually. It's like a very soft, flexible ring that you can just insert in the vagina, and it lasts for 3 months. But we know from studies the amount that's absorbed into the body is the same as placebo, so it doesn't get absorbed into the body.
Right, okay.
So even women that really have been told, no, you can't have estrogen, can still use vaginal estrogen. And that's really important, because I see a lot of women who can't wear underclothes, they can't sit down, they're really struggling, and they use the non-hormonal preparations, but it's not doing it for them. And that symptom will get worse with time. It's not like hot flashes that might come and go and improve. Once it starts, it gets worse. And we know about 70-80% of women have those symptoms, and about 8% have treatment.
Where could you get those? The ring, for example, where could you get it from?
You can get it from it has to be prescribed, even though it's safe. It should be available over the counter, but you can get it prescribed. But a lot of people are very scared because they think, oh, estrogen, breast cancer. So, but the evidence is very clear that they're not absorbed into the body, and so you can use them if you've had breast cancer, even if it's an estrogen receptor positive.
One of the questions that I've just seen come up a couple of times is letrozole, like the question with tamoxifen. Can you take HRT with?
No, because it won't really work, because letrozole is aromatase inhibitor, so it blocks estrogen in the body. So it's like wearing a suit of armour for estrogen. So if you take it, it's like the body will go, forget it. You won't, won't touch me. So there's no point, really. That's the thing. Whereas the tamoxifen does work differently.
So then that's pretty tough. If you're on letrozole, then like, what are your what can you do?
I think letrozole is a really harsh drug, actually, and I think it's very difficult. Some people actually tolerate it fine, so I'm not here to say don't take it, because some women actually are fine without it, or they cope. It all depends on how they respond without the estrogen, but also how long they're on it as well, I think, and the age and sorts of things as well. But I have spoken to a lot of women who, especially bone pain, as you say, they're waking in the night screaming with pain because they've got such bad bone pain. I mean, it's very barbaric. It's very cruel treatment. And I was talking to one of my friends who's an oncologist last weekend, and he does a lot of prostate cancer treatments. And I said to him, Dan, how much of the hormone blocking drugs do you give to men? He said less and less now, because they really can't tolerate it. 2 years,
interesting,
and 3 years, but after that, no way. I said, well, isn't that interesting? Because these poor women, I've seen women who've been told letrozole for 10 years. Like this, why are people doing this? And he said, because they're just in this sort of blinkered, this is bad, let's just go through this conveyor belt and let's look at the statistics, but they're not looking at the woman actually. And a woman,
and quality of life.
It is the whole quality of life thing, and that's what's very difficult to justify. And you know, I had a woman recently who is a paramedic. She's absolutely amazing, and she'd had breast cancer a few years ago and was really struggling. And she'd done a lot of research. She tried lots of alternatives. She was really fit and healthy in other ways. And she said, I've got a choice. I could go and live with my mother in the Outer Hebrides in Scotland and just exist for the next however many years I've got. She's only in her early 50s. Or I could consider taking HRT. I might have a shorter life, but that life is going to be amazing. And so she's now on actually HRT, and she's on testosterone as well. And she's just flying. But, you know, she might get run over by a bus tomorrow. So it's very, and that's, but she's made that decision. And I think this is, all of us who work with me in the clinic, we very much feel that we just are advocates, really. We're not here to say, yes, you can, no, you can't. It's like me saying to you, Helen, well, don't drink alcohol because that's really bad for you. And you might likely go, well, actually, I want to drink. You know? So, and I think it's a bit like this when we haven't got the evidence to say, but even if we did have evidence to say that it's bad, there are other benefits of HRT. So we need to weigh them up. And it also, you know, if someone's been diagnosed last week, the last thing they're going to do is take HRT. The last thing I would give that woman is HRT. But with time, it might be that she tries or whatever. But also there are different doses. So some people start very low, and some women we say, well, why don't you try it for a few weeks and then just review. And then in a few weeks, they'll either go, do you know what, I worry every day, I can't do this. And then they stop, and it's out of their system in 24 hours.
Is that right? 24 hours?
That's why you give it every day.
Right.
So if you're using the gel, use it every day. Other women use it, and then they go, my goodness me, my life's improved, my relationships improved, I've got my job back. I'm going to carry on because I want to live like this. I don't want to just exist. And that's a personal choice, you know.
How do you go to the GP to go on to get HRT? Because I feel like my GP would say, I'm not prescribing it.
Yeah, well, this, in an ideal world, women would see a menopause specialist, but for those of you that did tune in on the programme, you'll know that there are very few menopause specialists, and there's hardly any NHS menopause specialist clinics, which is absolutely shocking, actually, really shocking, when half the population will experience the menopause and there are health risks associated with it. So that has to change, really. I think it's trying to be really persistent, actually, and trying to do your homework yourself. So I don't know if any of you've seen this booklet here that I've written with some of my colleagues. It's called Been Through Breast Cancer, Tick, Did Someone Mention Menopause? And it's a guide to all things menopause for women after breast cancer. So it's available as a resource on my Menopause Doctor website under the resources section, and it's really detailed. We've written it, I've written it with a couple of doctors, and also we had advice from a patient of ours who's had breast cancer as well. And so it's very, it goes through all about symptoms, it goes through about the different treatments that we were talking about, so the aromatase inhibitors, tamoxifen and so forth. It goes through other treatments, so for lifestyle and everything else, and whether supplements make any difference. But it also does talk about HRT, just looking at the evidence. It's also talks about the vaginal estrogen preparation. So it's quite a good guide, really.
Right. What I'll do, if anybody's interested, I'll do a swipe up I'll do a stories later, and I'll do a swipe up to it so people can access it.
So I think, and I've also done a couple of podcasts, actually. For those of you know, under the resources section, but you can look under Spotify or
well, the podcast, I've got to say, you did a podcast with an expert, a chap, I want to say his name was Tony.
Tony Branson is fantastic.
Yes, that was a really great podcast.
So
I feel like it was number 34. I might be making that up.
Remember the number, it might be 39 anyway.
But it's really good.
Tony Branson, he's an oncologist in Newcastle, and he's been around for for a long time. He won't mind me saying that because he's close to retirement, but he's quite pro hormones to women who want them.
Yeah.
And again, he's very clear about choice, but he's really worth listening to. The other person I've done a podcast with is Avram Blooming, who wrote this book called Estrogen Matters. I don't know if any of you have seen. And
I've seen that.
It's quite a heavy book to read, but you can dip in and out of it. But he's an oncologist in America, and he's written this book. But what's very interesting about him is that his wife and his daughter both had estrogen receptor positive breast cancers.
Ah, right.
They both chose to take HRT. And that was because of the other health benefits of and looking at the bigger picture. And, you know, it's one thing when you're patient, you're advising, but it's a very different thing when it's your loved one or your daughter. And he didn't advise them to do it. He just wrote, you know, and gave them the evidence, and they decided in themselves. So that's
interesting. So that's Estrogen Matters.
Estrogen Matters, you can get it on Amazon.
The other question I saw come in was, what about Zolodex?
Yes,
is that in it?
Yeah, Zolodex basically gives people a chemical menopause, so it stops the hormones working in the body, and it can be temporary. So some people have Zolodex for conditions such as endometriosis, and then you can give back hormones as well. Sometimes people do it to block all the hormones in the body, almost so people can see how bad they're going to feel when they have their ovaries removed.
Right. That sounds quite harsh.
It is harsh. I really think I don't know. I think these treatments are really harsh for a lot of people, and I just think we need to have a bit more joined up thinking. You know, I'm not saying that every woman who's had breast cancer should consider HRT, and I'm not saying everyone should, but I am saying that people should consider these adjuvant treatments and how long they're taking them for, and what they actually mean to them as a person as well. And I think it's looking at their other health as well. So if I was seeing someone who had a really strong family history of heart disease or osteoporosis or dementia, then and that woman had tried really hard with her diet, with her exercise and everything else, that woman might benefit from HRT more than someone who didn't have that family history risk, because of the health benefits of HRT. So, and you know, the longer people are sort of since their diagnosis of breast cancer, the more likely they'll be fine with their hormones as well, if you see what I mean.
Yeah, I understand.
Women who've had estrogen receptor negative breast cancers can usually very safely take HRT.
Estrogen receptor negative, so like triple negative cancers, right?
Yeah. So again, there's not been studies, so we don't know, but it's thought, and Tony Ransom was very clear on the podcast as well, that their risks are the same as anybody's risks, really. You know, so there are some other cancers that can have estrogen receptor on them. So some types of ovarian cancer, most types don't. But a rare type of womb cancer called a uterine sarcoma can have estrogen receptors on it.
Right.
But again, you know, I've seen very young people who've had I saw one lady who was 23 when she was diagnosed with a sarcoma. She'd had her she'd had her womb removed, everything removed, and had quite strong treatments, and that was her menopausal from the age of 23. So, you know, it's when she became, you know, in time, she was only 25 when I saw her, but another 5-10 years, then she might decide to take HRT. So I think the message is that no decision is irreversible. So those of you, I'm sure there'll be some listening who think, oh, I'm never ever going to take hormones. It's ridiculous because I've been told by oncologist I can never take HRT. Well, you can never say never in medicine, and I think we have to, as doctors, we look at the whole, like our GMC, the General Medical Council, we look at consent. So we have to, obviously, if we take someone's blood pressure, we have to get consent to do that, to hold their arm, to do that. And some of it is implied, you know, if someone puts their arm out and I say, can I take your blood pressure? I know they're happy for me to do it.
Yeah.
But sometimes it's a more detailed conversation. If someone's having an operation, you have to sign a consent form, obviously. And giving women who've had breast cancer HRT is it is looking at the whole benefits and the risks and what it means for that individual. And if you look at the GMC guidance for consent, it's all about if the person understands benefits and potential risks, then it's a shared decision making, and that woman can decide. And she can decide even if the risks outweigh the benefits. You're allowed, because it's a personal choice.
It's about taking a bit of ownership, isn't it, over your
and I think it's
health.
It's really hard because, you know, a cancer diagnosis is a huge diagnosis, not just for you as an individual, but for your family, for your friends, for your work colleagues. And so obviously that all you're thinking when the diagnosis is made is, how am I going to survive? I'll do anything. You know, if someone said you've got to do 20 headstands every day, you would do it to make you.
Of course you would.
Anything. And I completely get that. So if then someone says, well, what about taking something that might make things worse? You'll never do it. But actually it's only a might, and it is weighing it up and reviewing it every so often as well, and looking at the symptoms but the health risks, and then deciding. But I think also knowing that, you know, if a woman decided to take HRT, well, she can stop it, you know? And I think that's what's really important, to know that there's always options as well.
And actually, like Kaz has just said on here, she doesn't want to just survive, she wants to thrive. And that's really, really important, isn't it? I noticed a comment, and I didn't catch the person's name, but she says that she's got advanced breast cancer. She's going to be on chemo for the rest of her life, but she is finding the menopausal symptoms debilitating. Could she speak to her doctor about going on HRT?
She totally could. And, you know, I think it's really difficult for people whose time is shortened because of their cancer, and they want to make the most of every day. We all want to make the most of every day. We could drop dead tomorrow, but for some people who know that their prognosis is different, then it's actually like saying, well, do you know what, I'd really like to smoke on my last few days or few months or few years, or I'd really like that gin and tonic that I've been denying myself, or a quick cake. So we have to sort of think, well, actually, what's the worst thing that's going to happen if someone's got a poor prognosis? Is it going to be that much worse by having a bit of hormones? And
and like you were saying, you can try these things for a bit.
Totally.
And if you don't feel enough benefit, or you stop. And if you feel too anxious on it,
then you stop. You know, the other thing is that we have to remember is that unless the women are taking aromatase inhibitors, which I've said block every estrogen cell in the body, women produce estrogen anyway. So a lot of women without estrogen tend to put on weight because our bodies are designed for estrogen. So our fat cells produce a very weak synthetic, not synthetic, but just not very nice type of estrogen. It's very different to the estrogen we produce in ovaries. So we see women sometimes in the clinic who have had breast cancer, they put on weight, they're not on any HRT, but they're menopausal. And you can do their blood tests and you find their estrogen levels are quite high, actually. And that's just their own bodies producing estrogen. And so then it's like, well, if I gave you HRT, you'd have a better type of estrogen and your level would probably be lower than what your body's churning out from these fat cells. So, you know, we have to remember that as well. And then we've talked a lot about estrogen, but testosterone is the other hormone that women produce.
So what's the deal with that then? When is that prescribed? In what situation?
So what we normally do is give women estrogen first, because that's like the building block of HRT. But if women have symptoms such as memory problems, fatigue, poor concentration, poor sleep, reduced stamina, low libido, then testosterone can help with those symptoms as well. Now, there isn't really good studies about testosterone with women who've had breast cancer, but it is thought to be neutral on the breast tissue and won't really have a good or bad effect on breast cancer. And so then people will say, well, why can't I just have testosterone then? Do I just bypass the estrogen?
Yeah.
Now, it can get a bit more complicated because, as you probably know, all our hormones are working together. So if a woman doesn't have any estrogen or very low levels of estrogen in her body, then if you give testosterone, the testosterone will just get converted into estrogen in the body, because that's what the body does. Whereas if the body's clever, isn't it? It is clever. But if women have got a bit of estrogen, then you can give testosterone and it will work on the testosterone receptors.
But is there a danger of growing like more facial hair and that sort of thing?
No, so when we give testosterone, all we're doing is topping up the bits that are missing. So we're not giving too high a doses, so no one's going to turn into a man or grow a beard or moustache.
Right.
It's literally just topping up what's missing. And we often do blood tests to make sure that women who take testosterone are in the female range. So it's just putting them back to how they were when their ovaries were working properly.
Got you. And can you take testosterone if you were progesterone positive?
Yeah, so again, it's not progesterone. So
right, so that's
they don't test, as far as I know, any breast cancer for testosterone, because it's not usually there. It's not usually the receptor.
Yeah, got you.
So, there are some women who say, well, do you know what, I would like to just try testosterone on its own, just to see, knowing that some of it might convert to estrogen, and some consultants do that more than others. I think because they feel a bit more comfortable, I suppose, not writing estrogen on the prescription. And again, it's an individual choice. Some of these decisions are quite difficult to make, certainly during an IG life. But it's food for thought. And I think what I want to sort of portray is that no one can be refused something. I think that's what's really important.
Yeah. And I think, if anything, what these conversations do is just ignite those questions within and empower everybody that's listening to actually ask those questions and go and speak to their, well, if there is a local menopause clinic, or go to their GP.
Yeah, I think so. I think it's trying to find the right person to talk to and listen to, and it might be it's a breast nurse, cancer nurse, or it might be a breast surgeon more than It really depends. But some people aren't in touch with their oncology team anymore because they've been discharged, because they've done so well, but then they're still struggling, and so it's certainly, and then it is looking at which are the symptoms that are affecting you as a woman the most. And if they are the sort of local symptoms, the vaginal symptoms, everything else, then definitely I would really 100% say try some vaginal.
Do the topical. And is there anything other than HRT that you would say to help?
So yeah, I mean, that's a great question. And there are all these natural sort of products that are marketed. Generally, if something's got menopause in the title with a product, I would avoid it because it's marketing. You have to think, what are you taking this alternative for, and how's it going to help you? So some people find if they're having really bad hot flushes, then something like sage can help.
Yeah.
Some people find a low dose antidepressant can help. So the antidepressant isn't given for the low mood in that circumstance. It's given for the flushes, and it can help. There are other drugs like gabapentin that can help with hot flushes, but they cause quite a lot of side effects often.
Right. I actually had acupuncture, which really helped my hot flushes. It really helped regulate them. And drinking less coffee, having coffee seemed to like kick it off.
Coffee, red wine, spicy foods can. Acupuncture is great because it's not really going to do any harm. Some people find some meditation or aromatherapy can help. But if it might be something like that can be good for the symptoms, but then it's also thinking about, being menopausal, I've got an increased risk of heart disease, osteoporosis, dementia. So what can I do that doesn't include hormones that's going to reduce the risk of that? So vitamin D, obviously we all should be on. Looking at calcium in our diet. Some people take a good quality fish oil because there's some evidence to reduce risk of heart disease. Looking at our diets, because we know that less processed food is good for heart disease and dementia. You know, more fresh fruit, looking at our gut microbes. You know, what are we helping? So that side of things is really important, whether you take HRT or not. You know, and so rather than thinking, is this going to help my symptom, it's also looking at, is this going to help my future health? And that's where all these marketing things don't think of a woman's future health in the same way. I think that's what's...
What about alcohol? Is there anything that you're like, you need to cut that out?
In terms of... Again, that's an individual choice. So obviously alcohol can make symptoms worse. If people drink too much, then it can increase risk of osteoporosis and heart disease and so forth. You know, some people really like a drink and think, well, I'm going to take that risk. That's fine. You know, other people don't. So it's, and this is where, you know, if you look at the risk of breast cancer in women who haven't had breast cancer, so the risk of breast cancer with the worst type of HRT, not that HRT is all bad, but the sort of synthetic types, the increased risk of breast cancer that's been reported is less than the risk of a woman who drinks 2 glasses of wine most nights.
Wow.
So, you know, so we have...
That's so interesting.
But that's not saying that drinking 2 glasses of wine is bad.
No.
That's saying that the risk is really low.
Yes.
You see what I mean?
Yeah, absolutely.
So, you know, and there are a lot of people that drink more than that. So that's why you have to look... You always have to take a step back and look at the bigger picture, and that's what we've tried to do in this booklet, to just sort of hold people's hand a bit, really, and sort of think about things that probably no one's spoken to you about.
Yeah,
no one's,
it's so great that you've put that together, and I'm looking forward to being able to share that with everybody. I'll do that later on tonight. I had a couple of questions about mood swings. It's definitely something that I suffer from. I can go 0 to 60 at the flip of a switch. Is there anything natural that can help that? Any supplements or...
It's really difficult because often it's related to the low estrogen and low testosterone, actually.
Right.
I think some people, obviously, looking at mindfulness, looking at meditation. I mean, I do a lot of yoga, especially Ashtanga yoga, and that certainly keeps me more calm and more focused. And, you know...
How often do you do it? How often?
I do yoga at least 3 times a week.
Right.
But I do a lot of balancing postures, and you know, if I'm doing a headstand, I'm not thinking about the 50,000 things I need to do. So it's a really good time for me to do. But that's me. Other people like to go running or go for a walk.
Yeah.
You know, I think having time. I've got a podcast coming out soon about mindfulness, actually, with Claudia Brown, who's a yoga teacher. She's brilliant. But she was talking about. They had a group session of mindfulness chocolate eating. So it wasn't just eating that chocolate, it was about the wrapping and the smell and the texture. And And it is that whole thing about having time for you. And a lot of women who had breast cancer have got families or children, or they've got their jobs, or they've got partners. So actually, some of the symptoms or the mood swings is just because you're just bloody exhausted because you're doing everything. So just having a bit of time, or even in the shower, you know, find a really lovely smelling soap or shower gel and just indulge.
Just get lost in it.
Yeah, and I think that's what's really important. And I think also, you know, not just women with breast cancer, but women who've had, or men who've had any disease, it's like that's almost identifying them as who they are. And actually, I'm sure most people listening would agree, they just want to be seen as women, actually.
Yeah.
Rather than, you know, oh, that's Helen who's had breast cancer. Like, no, that's Helen who's
definitely.
And I think it's sort of trying to allow your body to be a bit more liberated and sort of freed almost from it, because otherwise it's like this sort of Damocles over you every day. You're thinking, oh, is this going to be, you know, is it going to come back? And I think that's what's really difficult for so many women.
Absolutely. And I think as well, there's this whole thing, and I know I've said it before, where you sort of feel like, I should be grateful that I've been, you know, that the cancer's been fixed, and actually I am, of course I am. Everybody it is, you know, and but it is about quality of life.
Yeah. I mean, I've done a podcast. I've done a couple actually with women who've had breast cancer. One is a young well, I call her girl, but she's in her 20s. And then another is someone who's menopausal, who decided after 10 years to take HRT. And, you know, it's very interesting listening to how they've been suffering, but also how they were neglected actually for a long time. And I think, you know, someone said to me, you know, you live every day, but you only die once. And it is about living and how you choose. You know, I as I've just said, do yoga. I don't drink alcohol. I don't drink caffeine, so I don't eat chocolate. For a lot of people, they would hate that. But actually, I'm fine with it. And I get migraines if I do all those things. So it's fine. But it's about having a choice. But it's also, I think, making a choice and not letting others judge you for it. Because I think we've had quite a few patients who've taken HRT and then their relatives have gone, no, you mustn't do that. That's so dangerous. You know, you've gone through all this treatment. That's awful. And so then that's very hard, isn't it? So I think
it's really hard,
having the strength to just go, do you know what? It's my life, actually. I think as I've got older, I've got more selfish. Thought, do you know what? I've got to look after myself. You know?
I can definitely feel that coming on as you know.
I think, you know, you've got children, I've got children, but I do need time to myself. And you know, that's why I do yoga. I have an hour to myself doing, and it's just heaven. But yeah, I could do an hour of cleaning the house or dishes, but they'll still be there after yoga.
You're so right.
And I think as women, we always feel guilty. And I think also women who've had breast cancer, like you're saying, feel so guilty that they're looking at something that might increase their risk, that they're always pushing it to the back of their mind. But every day they're being affected by menopausal symptoms. And that's where it's a very personal decision.
It really is.
To be made, but also re-explored and revisited as well, I think is really important.
And just one last question, if you don't mind. A couple of people have asked, do you take HRT yourself?
Yeah, of course I do. I wouldn't, it's my one conflict. I don't work with any pharmaceutical companies. I don't do any paid work with any pharmaceutical companies at all, but I do take HRT. But do you know what, Helen? I wouldn't be working as a doctor without it because my brain had stopped functioning. I couldn't remember anything. I was very irritable. I was not sleeping well. I had lots of symptoms, but I really worried about my mental state actually. And but also I worry about osteoporosis and I worry about dementia. So one of the reasons that I take it is for, you know, to try and reduce my risk of these conditions. But there's no point taking HRT and eating McDonald's and smoking, you know.
No, exactly.
Well, but it enabled me to, because I got to a stage where I didn't even want to do yoga. My joints were too sore and stiff. My energy was...
It's just not...
and then
what's it all about?
What's it all about, you know? And I think, you know, no one knows what's around the corner. And
no, they don't.
Like I said at the beginning, we have to think, what do most women who've had breast cancer die from? It's not from breast cancer.
No. So, dementia or heart disease.
Yeah, and so I think that's really important. It's looking at, you know, everyone focuses on death actually when you've had cancer, but it's not about death. It's about the
no, it's not. Yeah, absolutely.
Which is really important.
Absolutely. Look, I don't want to take up any more of your time. I know you're an extremely busy woman.
No, but I hope that's helped. I mean, I think it's probably
enormously.
More questions than answers, and you know, it's a very difficult thing, and I'm very grateful. I can see that the Zoe's little bee flipping, so I know she's been answering lots of questions. But
yes,
you know, there isn't right to have a look at this. There's also
I will do. There was a charity. What was the charity called that you wanted me to tag?
So the charity is called the Menopause Charity. So it's www.themenopausecharity.org, which has just been launched last week. And the first thing that we've done as a charity is given free menopause education to every GP practice in the NHS in the UK and Ireland, and we've already had over 5,500 people downloaded the course.
That's amazing. But you have an app as well, don't you?
Yeah, we've got an app called Balance.
Yeah.
So it's a free app for women where you can download information. It's all evidence-based be part of a community, and also monitor your symptoms as well. There's also another booklet here which is called Cancer Treatment. Did someone mention menopause? So this is for anyone that's had cancer.
So it's not just breast, it's
so
any cancer.
So
yeah.
The blue one is for breast cancer, and this beige one is for just I say, but any other cancers. So people might find that useful as well. So they're both available on my menopausedoctor.co.uk website.
Right, not the menopauscharity.org. So what was the other one?
menopausedoctor.co.uk.
Yeah, okay. I'm going to put that up there as well. Thank you so much for your time. Everybody else is saying that it's really helped them, so I can't thank you enough.
Well,
thank you as ever, and no doubt I'll see you on the Lorraine show soon, hopefully. Yeah. All right. Have a lovely evening. Thank you, and thanks everybody for joining us. It was wonderful. Thank you.
Bye.
Cheers. Bye.